Good afternoon and welcome to the Euro webinar on genetics in stone disease organized by the European School of Urology Online. Before we start, I would like you to know that the webinar is accredited with one continuous medical education point. And you will find tomorrow a link online to find the webinar online and to fill in a questionnaire. And after filling the questionnaire, you will get your certificate. I'm Skolarikos Andreas, Professor of Urology in the National Kapodistrian University of Athens, Greece. With us is Mr. Pietro Ferraro, Associate Professor of Nephrology from Italy, and Sabir Moochhala, Consultant Nephrologist and Senior Lecturer at the UCL Royal Free Hospital from London, UK. The genetical disorders are not uncommon with our patients and with patients with urinary stones. So we will discuss when and how we unreveal genetic predispositions in our stone patients, and we will focus on primary hyperoxaluria and cystinuria. So please enjoy and remember to fill in the questions and be active on this webinar. So Professor Ferraro, please start with your presentation.
Thank you, Professor Skolarikos, and thank you to the organizer for the invitation. So I'm now sharing my screen. So these are my disclosures. And this is the layout of my talk. I will give a brief review of the epidemiology of kidney stones. Then we'll review the heritability at large of kidney stone disease. Look at the impact of monogenic forms of kidney stone disease, and then look at some recent data on the polygenic structure of idiopathic kidney stone disease. So starting with the epidemiology, we all know very well that kidney stone disease is a really common condition, and the numbers are rising. So far, we have about 10% of our population in Western countries that are affected. Another characteristic of kidney stone disease is the high recurrence rate, ranging as a function of previous stone episodes from about 3 to more than 18 per 100 person years over time. So this condition is also able to put a dent in the health systems. In fact, it has been estimated that the amount of direct and indirect costs, for example, in the US for this condition is about $4 billion per year. So it's a relevant condition, and we have to be aware that there is a heritability of this condition. In fact, we know that if someone has a person in the family affected with kidney stones, their probability of developing a kidney stone over time will be more than double compared with someone with no history, with no family history of kidney stones. And this has been shown in the health professionals follow-up study cohort in 38,000 participants. So this can be due to either heritability, so either genetics, or to shared environmental dietary risk factors. So in order to disentangle this, we have data from a very large, actually from the overall Swedish population, that confirmed that having a positive family history for kidney stones is a risk factor for both men and women. But the authors of this study also looked at the relationship between the proband and the other affected members of the family, showing that, for example, the spouse of a proband will have about a 30% higher risk of forming stones, which can be imputed to shared environmental factors. But if you look, for example, at having one or both parents affected, the risk is 2 to 4 times higher. And also having one sibling is associated with a 90% higher probability of forming stones. And as you can see, 2 or more siblings, the risk goes up very, very high. A more refined approach to this problem was performed by David Goldfarb in a in a twin study of the vet registry using data from 7,500 male twin pairs with self-reported data on kidney stones and dietary habits. And this also showed that the monozygotes had a higher risk of stones compared with the zygotes, and also that the estimated role of genetics as opposed to environment was about 56%. So about half of the risk of having a stone could be said to be heritable. Interestingly, these data are similar to those found in 3 large cohorts from the US, the Health Professionals Follow-Up Study and the Nurses Health Study 1 and 2, in which we basically looked at the residual risk of having a stone after removing the effect of known environmental factors such as low fluid intake, animal protein, sugar sweetened beverages, inadequate calcium intake, high BMI, and inadequate intake of fruits and vegetables. And we ended up with about 45% risk not explained by these variables that could be attributed to genetics indirectly. There are a few studies that looked at the heritability of individual urinary components. There is one case control study performed on 480 subjects with high urinary calcium excretion and the same number with low urinary calcium excretion. In these two groups, the authors compare the frequency of variants in 40 genes known to be involved in calcium metabolism. However, they did not find any association between rare variants and urinary calcium, although they found a nominal association between a common variant of Claudin 14, which seemed to be protective on urinary calcium. There is also a classic twin study performed on 1,747 female twin pairs that estimated the heritability of urinary calcium as a continuous trait to be about 52%. So conceptually, if we want to tackle the role of genetics in kidney stone, and if we look at kidney stone disease as a heterogeneous group of disorders, we know that a subgroup of these patients will have a definite cause for nephrolithiasis. So they might have structural abnormalities, known abnormalities of calcium metabolism, such as primary hyperparathyroidism or sarcoidosis. They may have malabsorption, the use of drugs that can directly or indirectly lead to stone formation. They have infection stones. And within this group, they can have monogenic conditions. The rest can be labeled as idiopathic kidney stones. So our role would be to focus on the relative frequency of monogenic conditions, and I will show you some relatively recent data. The investigate factors that might be associated with monogenic conditions, thus increasing the likelihood of diagnosing them. And finally, we might want to investigate the genetic drivers of the remaining large group of idiopathic kidney stone disease. So moving to monogenic forms of kidney stone disease, these are classically thought to represent about 3%, 3 to 4% of all kidney stones. There are several lists compiled of genes whose variants can give either calcium or non-calcium stones. These are generally, this list is non-exhaustive, but you can see that some conditions can be caused by more than one gene: primary hyperoxaluria, idiopathic hypercalciuria, autosomal dominant hypocalcemia, Bartter syndrome, Danon disease, and so on. These lists are updated very often based on case reports and case series. And there are also some genes that are associated with, that are cause of monogenic non-calcium stones, and these are cystinuria, renal hypouricemia, APRT deficiency, xanthinuria, Lesch-Nyhan syndrome, and so on. So the next speakers will focus on the two major calcium and non-calcium conditions, namely primary hyperoxaluria and cystinuria. What I'm not going to do, I'm not going to talk about the remaining 30 or so conditions in these few minutes. For those interested, I can point you to a very recent and very well done review on this topic. But I'm more interested in showing some data regarding the the actual prevalence of these conditions. So there have been a number of studies recently, all performed by the group of Professor Hildebrand, that tackled with these condition. So these are studies published between 2015 and 2017. And as you can see, they are slightly different between each other in terms of the amount of pediatric patients included. The population generally included patients with either nephrolithiasis or nephrocalcinosis or a combination of both. 2 of 3 studies used exon sequencing with a panel of 30 genes. And if you match these panel with the list that I showed you earlier, you can see that they are not covering completely all the monogenic causes of kidney stones. But the third one, published in 2017, adopted a whole exome sequencing approach. In all cases, the known secondary causes of kidney stones were excluded. So I tried to combine the data from these studies. I would like to focus on the fact that these are not necessarily the populations that we see in our standard outpatient clinic, either nephrological or urological, because these are enriched with pediatric populations, enriched with recurrent cases, with familiar cases. So in a way, it's expected to find a rather large number of monogenic conditions. Anyway, the yield of monogenic conditions when combining data from all the 3 studies is 18%. And as you can see, the majority of these cases were represented by cystinuria, 5.4%, hypophosphatemic rickets, and FHH&C and primary hyperoxaluria. Interestingly, if we divide the overall yield by age of onset, by stratifying in early versus late age of onset, and by this I used a cutoff of 18 to 25 years because it was not possible to disentangle perfectly these age groups. By the way, you can see that, as expected, the yield of monogenic conditions in the late group, those with the age of onset greater than 18 to 25 years, was reduced, was 11%. And when we remove from these patients with conditions that could be diagnosed without genetic analysis, potentially, such as mainly cystinuria, because other conditions were not present in this group, the proportion goes down to 13% in early and 4% in late. So this is more or less the amount of the yield that we would expect by implementing genetics in our adult clinics. However, this doesn't mean that this shouldn't be sought. Actually, we should strive to diagnose monogenic conditions. First of all, because this would improve prognostication, including information on the potential slope of kidney function over time and involvement of other organs. It can be possible to implement genetic counseling on these patients, and also for certain conditions, it's possible to adopt targeted treatment strategies. For example, for cystinuria, we may use thiopronin. For primary hyperoxaluria, we can make a trial with vitamin B6, or with more recent RNA inhibitor interference strategies. For infantile hypercalcemia, we might want to avoid vitamin D supplementation, which are things that we would not do if we didn't know the genetic diagnosis. So when to suspect such conditions, some elements might give us a clue: metabolically active disease, age of onset before 25 years, a positive family history, consanguineous parents and associated abnormalities in terms of involvement of the kidney, of the bone, of the ear and eyes. In terms of lab imaging, some of these elements can provide a diagnosis without the need for the genetics, in particular cysteine, dehydroxyadenine, or xanthine in either the stone or as crystals in the urine, high cysteine in 24-hour urine collection. Other conditions such as non-calcium oxalate in the stone, calcium phosphate or uric acid as crystals in the urine, high calcium oxalate uric acid or pH or low citrate in 24-hour urine, or the presence of nephrocalcinosis may make a suspected diagnosis, although I might stress that there are no systematic studies looking at the performance of a combination of these elements. So finally, I would like to give a brief review of the polygenic structure of idiopathic kidney stones. So we are basically moving from conditions that are rare, but with variants with a strong effect on phenotypes, to conditions that are common with a number of variants that have a relatively small effect on phenotypes. And this is the field that is optimally analyzed by GWAS studies. In fact, to the best of my knowledge, there are 7 large population-based GWAS studies published on about 52,000 cases and more than 1 million controls, mostly of European and East Asian ancestry, with the phenotype being not very detailed. It's just a history of kidney stones in the in their history, and these are the combined results of these 7 GWAS studies. As you can see, variants have been reported in 25 genes. The most consistent hits included SLC34A1, which is a sodium phosphate cotransporter, alkaline phosphatase, aquaporin 1, claudin 14, and these are all genes coding for proteins that, for the most part, are involved in the renal handling of water and electrolytes, not unsurprisingly. So just to give a final show how this actually works in practice, this is a recent study published last year in which the authors used more than 7 million single nucleotide variants to create a polygenic risk score that was subsequently validated, and the authors showed that one standard deviation increase in this polygenic risk score was associated with a 25% higher odds of SONS. And interestingly, it was the performance was similar in those with the high as well as low clinical risk, defined as those with the high or low BMI, history of gout, diabetes, or hypertension. So in conclusion, we must be aware that genetics and environment play an important role in kidney stone disease. Monogenic forms are relatively rare. However, their diagnosis should be sought as they could impact the patient prognosis. Genetics are also thought to play a role in idiopathic nephrolithiasis, and certainly increased knowledge of the genetic architecture of idiopathic kidney stone disease may in the future allow precision medicine approaches and open the way to novel treatments. With this, I concluded, and I thank you for your attention.
So, Dr. Ferraro, thank you very much, Professor, for the very nice presentation. We have only one question up to now, which is related to hyperoxaluria. So the next speaker will answer to this, and please prepare yourself. I have, as we don't have a lot of time, but I have 2 questions. First of all, what is the clinical practice, the clinical significance of all the genes that can be altered, and who, that's the first question, and who actually is going to perform the gene analysis for us? Is it the urologist? Is it the nephrologist? We should ask for specific genetic counseling. And how often in clinical practice you check upon the patients and their relatives?
Okay.
In general, as a general comment.
Yeah, so in general, I would say that in terms of clinical practice, I might point out that the guidelines, and I guess you are very familiar with them, don't actually at the moment don't give us any specific indications for genetic evaluation. However, when there is a suspect of a monogenic condition, I would like to keep separated the known monogenic conditions with the role of genetics at large in idiopathic kidney stones, although they might be somehow related. However, when there are clinical or laboratory imaging elements that make us suspect a monogenic condition, that would certainly be a reason for further investigation, because for some conditions the laboratory elements are not enough to perform a diagnosis of a genetic condition, of course. So, and who should do it? I mean, whoever has to suspect a condition, you have to know it in the first place. So either urologists or nephrologists that are skilled with and are familiar with the with genetic or otherwise metabolic forms of kidney stones could do this, and certainly the advice and the guidance of a geneticist should be sought. So this is what, for example.
So we have, thank you, Ferrara. We have actually one relative question from one of our attendees. So what would you recommend as a genetic screening procedure for lithiasis patients? It's pretty much the same question, I would say. So what do you recommend as a screening tool?
I would not consider any screening in terms of genetics. It has to be driven, in my opinion, by clinical suspicion.
Okay, and I will reply to one of the answers of one of the questions, because it is more a urological question, I would say. If we have to use the same residual fragment size cutoff for genetically associated stones, there's no evidence, but I suppose the answer is yes. So thank you very much, Professor. I will move to Sabir. Professor Moochhala, please proceed with your presentation.
Great. So thank you and good evening, everyone. Thanks very much to the organizers for kindly asking me to talk about this. This is going to be a 15-minute quick guide to primary hyperoxaluria, which I'm hopeful is going to be practical from a urology point of view. That's my aim anyway, and following on from Manuel's talk about the basics of genetics. Here are my disclosures. So the first question really is about what do urologists actually need to know about primary hyperoxaluria? And the first thing to say is that unlike some of the other rare kidney stone diseases that we've heard about, this one is in the very large category that we normally see of calcium oxalate stones. So on that basis, it's very hard to make the diagnosis just on the stone type alone. And even if we try to be clever and look at the distribution between the different subtypes of calcium oxalate stones, there's still no particular clues. So that does make it a bit harder. And then just to make it even more hard, we've found that actually there's more than one syndrome connected with hyperoxaluria. So primary hyperoxaluria syndromes, there's 3 genetic subtypes that we know about. There may be more. And there's also at least one other type of hyperoxaluria, which is due to mainly gut pathology, but can be due to other forms of malabsorption. So we've got to try and differentiate between all of those as well. And the other thing that's important is that this can present at any point to almost any specialty, but usually to a urologist and quite often to a pediatrician. Although this is actually it's actually a problem with stones, but we mustn't forget it's actually a multi-system disease. And I would say it's actually not even a kidney disease. It's actually a liver disease. And I'll show you, explain how this actually works. But it's a liver disease that causes not just a kidney problem, but it actually causes a multi-system problem. And that's why it's really, really worth knowing about this and trying to diagnose it at a very early age, or as early as possible, so that we can prevent some of the later complications. And it's also worth pointing out that among all of these rare forms of monogenic diseases, as you heard from Manuel's talk, this accounts for in total about 10 to 15% of all cases of monogenic disorders that we would see in any urology or nephrology clinic. And so each one is maintains quite a small proportion, but when you add them all up, it's quite a large proportion. And so therefore, we've got to try to become skilled at trying to diagnose them. The other thing that's important about primary hyperoxaluria, particularly the type 1 form, is that it's actually a progressive disease. So it can present at any age. It's a genetic condition, but it presents at any age. That's quite unusual, but it does happen. And it can present, if you look in books and in papers, you'll see that it tends to, you see graphs like this, where you'll see a gradual worsening of function, let's say over time, and a gradual increase in the stone burden, perhaps the nephrocalcinosis burden, and eventually you'll see that it has systemic consequences. So on the heart, calcification over here, you can see demineralization and fractures of bones. You can start to see an effect of this thing called oxalosis, which really looks like a bit like calciphylaxis, if you've ever seen that. You quite often see them in renal dialysis patients, and it can cause other multi-system disorders. Once you get to this stage, things have become pretty bad, and your chance of curing the patient or making them any better is really quite low. But it's also very important, not just because this could get worse, but because there are potentially now treatments available for this condition. So that's why recognizing it early is important. But kidney function doesn't always deteriorate linearly. It's quite often stepwise, and it can be at various times, and it can go up and down in the same way that you would notice when you have a patient who presents to a urology clinic or has an operation and has an acute kidney injury associated with that. You'll see it quite often go up and down, but it's the trend that you're looking for, and that's what's important. So it really is worth making the diagnosis. There are, of course, benefits to the patient in terms of stratifying their individual risk, of trying to nowadays give them more individualized treatment, but also benefits potentially to the family. Now, this can apply even though this condition is autosomal recessive, because there are, even within families with this particular type of inheritance, you can see clustering of cases. And of course, there's benefits for research, because we now try to enter all of these patients with rare conditions into registries. And again, each country has its own method of doing that. Within Europe, there are European registries available as well. So now I'm going to talk to you about the pathophysiology. I'm going to try to present this in as clinical a way as we can. Right, here is a liver cell. This, remember I said it's a liver disease, not a kidney disease. So this is the edge of the liver cell. All of this is a liver cell. So over here inside the liver cell, we have a peroxisome, we have a mitochondrion, but it doesn't matter, this is all within the cell. And you can see that these pathways are continuous. And what they're trying to do is get rid of this thing called glyoxylate and gradually move it along, and eventually convert it into this thing called glycine, which then it's soluble, it gets excreted, and there's no problem at all. And similarly for some of these other waste products, that's what the liver does. Here's what happens when it goes wrong. If there is a defect in any of these enzymes, so this is the enzyme that affects pH type 1. If there's a defect in this enzyme, you're going to affect this part of the pathway. And similarly with the other types. And what will happen is that when you affect that part of the pathway, two things happen. You get an increase in the precursor substrate, but the body always tries to find a way to move things along. So instead, it will go down another mechanism, and this is glycolate oxidase, and form oxalate. Oxalate, not a problem for the liver. Liver's very happy. It goes out into the circulation. Big problem for the kidney because it's not soluble. And same over here. For pH type 2, there's a defect in this enzyme over here, a metabolic abnormality as a result of a mutation, and it means it's not working. So again, the body finds another way to get rid of the glyoxylate, in this case via lactate dehydrogenase, giving rise to oxalate. And for pH type 3, it's not clear what the mechanism is, but we know it's within the mitochondrion, and a similar process, it's going to generate oxalate. So these are the problems that we need to try and solve. And the great thing about biochemistry is that you can find workarounds to see if we can get past some of these problems. Of course, the ideal way to treat this would be gene therapy to fix the genes that are defective. We haven't quite got there yet. These in green are the two established therapies for primary hyperoxaluria. So these are the things that are so far shown to be standard treatments. It doesn't necessarily mean that they work. Pyridoxine is vitamin B6, works in approximately 20% of cases of pH type 1. So in other words, that's not many patients. It's only in primary hyperoxaluria type 1, and it's only a small proportion. And this is a combined liver-kidney transplant. It's not exactly an easy thing to do, comorbid, causes a lot of problems, and quite often by the time it's put into place, the patient's already suffered quite a lot of systemic complications, and it's obviously not without risk. But once you've done the liver transplant, it does mean that it's curative, because the patient no longer produces abnormal enzyme. And then there's another set of drugs that can work on the basis of bacteria or bacterial enzymes to try to digest oxalate in the gut. So that's another way of trying to attack the problem. There are new treatments now. So we've got some work being done on these new drugs that end in CERAN. CERAN means small interfering RNA. These are molecules that I'll tell you about in just a second, but these are workarounds. So what they do is, instead of allowing this pathway to continue to produce insoluble oxalate, instead what happens is it blocks that pathway and makes the metabolism go via a different route that doesn't cause the formation of an insoluble substance. And similarly over here as well, and other drugs are available as well. The one thing over here, dialysis, is again a treatment, but it's the least useful treatment and doesn't really work very well in terms of removing oxalate at all. So this is using the latest drugs, which are really worth knowing about. I'll explain how these work. These siRNAs are simply just a strand of RNA. They're the backwards strand of RNA, and what they do is they fit onto the RNA of the target protein. And the whole point of this is it blocks it, it stops it from working. And the other really good thing about the technology that's been developed for this is that it's specific for the liver, which is great, because we don't want it to affect the same gene or enzyme protein anywhere else in the body if it exists anywhere else. And that's useful because PH1, as I said earlier, is actually a liver disease. And when this has been looked at in clinical trials, you can see that there's been so far an excellent response if you're using urine oxalate as the marker. So over here with this particular drug, you can see there's been about a 65% drop in the urine oxalate from baseline when using this substance to try and block that enzyme, and it drops the amount, and it seems to be a consistent finding over a period of time and quite well tolerated. And even the substrate, the increased production of glycolate, doesn't so far seem to have had any ill effects, although we will, of course, that will be monitored in due course. This is another drug, again, that was in that schema earlier on, similar sort of effect. You can see that there's about 65% reduction as well in the urine oxalate with that as well. And again, because this one is acting in a different location, it might potentially be useful in not just in pH type 1, but it might be useful in other forms of primary hyperoxaluria. So this might be, for the first time, a particular disease, a genetic stone disease that could potentially be preventable. And it really just makes us think and makes us realize that rare stones really are worth looking for. Remember, as I said, this one's slightly more difficult because the stone type is the same as common stones. That doesn't really help us that much. So we have to think of other ways in which this disease might progress and present so that we can identify it. So obviously, if it happens in the pediatric population, that's a bit easier because most of pediatric centers will be allied to a metabolic service that will or a genetic service that could look into this in more detail. The problem really happens in the adult population, and we do diagnose quite a lot of primary hyperoxaluria in the adult population. And it's also worth pointing out that there could be other genetic hyperoxaluria subtypes that we don't even know about yet, and that's also another reason why we need to start thinking about looking at these in more detail. There will be some guidelines coming up on diagnosis and on treatment, which are being updated by this, which is the European Hyperoxaluria Consortium. They have a website, and those guidelines will hopefully come out later on this year. So I'm just going to leave you with some practical points. I said, well, we should send every stone for analysis. That may not help in this particular case, but it's still worth doing. But these are the questions that you need to ask your patient in clinic or after they've had their operation. What age did you have your first stone? That's very instructive. Quite often it's earlier than you might have thought, and it may not have been an actual stone. It may have been some other kind of symptom. And does anyone else in your family have stones? Also very important. You heard that already from Manuel's talk. But this is the other thing. Check their kidney function. Yes, that we always do that. That happens, of course, when patients come into hospital. But the point is that if they've had an acute kidney injury at the time of the stone operation or shortly afterwards, then it's quite common to allow that to be just attributed to the acute kidney injury episode and just say, oh, well, it'll get better. But the key point is there needs to be some mechanism for checking that that's happened, because what you're looking for is a progression over time in the creatinine. And that's going to be your clue as to the presence of something else that could merit a referral to a nephrologist. And that's all I have to say. Happy to hand that back to my chair. Thank you.
So thank you, Sabir. That was a very clear-cut presentation, I would say. We have one question regarding the serums. If they decrease the 24-hour urine oxalate to physiological levels, or the patients are still hyperoxaluric when they are on serums?
Yes, so the majority are still hyperoxaluric as defined by the upper limit of the so-called normal range. The question really is whether or not it even needs to be reduced to physiological levels for it to be deemed as effective. And that information is still to be found. So there are a certain percentage who do get into the physiological range, but it may be the case that it's not even necessary for the majority of patients to produce an improvement. We will wait and see.
Okay, thank you for the answer. And we have one comment that you had from the audience, from the attendees, that you had a very nice presentation. So I think I will move with my presentation. So hello again. We will discuss about epidemiology, the genetics, the diagnosis, management, and follow-up of cystinuria and cystiniuric patients. I have no conflict of interest. Cystinuria is a rare disease affecting 1% of the adult and 3 to 10% of the children population, showing a prevalence ranging from 1 to 2,000 and to 1 to 100,000 in different countries. The wide range indicates the lack of knowledge on the exact genetic basis and environment and background of this disease. Cystinuria actually affects young people, with the majority of cases diagnosed from 5 to 20 years of age, and more specifically between 11 and 20 years of age. It's an important disease because it affects the patient quality of life as every other stone does, but also because it also affects kidney function, with 70% of the patients with cystinuria ending to chronic kidney disease and end-stage renal disease. Cystinuria, sorry, I have to move back. Cystinuria is is a disorder of the proximal convoluted tubule reabsorption of filtered cystine and the basic amino acids lysine, ornithine, arginine, and this is the abbreviation for CoLA amino acids. The inability to reabsorb cystine leads to accumulation and subsequent precipitation of stones of cystine into the urinary tract. There are, sorry about that. There are two transport systems in the proximal convoluted tubule: the high affinity system at the third segment of the proximal tubule, mediating 10% of the cystine uptake, and the low affinity system at the first and second segments of the proximal tubule, mediating 90% of cystine reabsorption. When the system is faulty, urine cystine concentration increases to supersaturation, and crystals forms and aggregate to cystine stone. It goes back, then inside, then in front. And this is the transepithelial dibasic amino acid transporter that you can see on the slide. The transporter protein is encoded by two solute carriers that and solute carrier gives the abbreviation SLC for genes. The SLC3A1 located in chromosome 2 and the SLC789 located in chromosome 19. The 3-1A gene encodes for BO plus AT subunit of the transporter, while the 7A9 gene encodes for the RBAT subunit. When the transporter works well in normal individuals, the cystine is transformed to cysteine in the proximal convoluted tubule cell and then excreted to blood. Today, there are 160 different mutations in the 3A1 gene and 119 mutations in the 7A9 gene identified. The type of mutations include missense and non-missense mutations, the prognostic significance of which are unclear. And there are a lot of new mutations still identifying, explaining in part the diversity of cystine population. Recently, a new transporter, the AGT1 encoded by another gene A13, was discovered, but its significance remained to be elucidated. The typical traditional, the typical traditional mode of inheritance for cystinuria is the autosomal recessive, meaning that from heterozygote parents, 25% of the children will be affected with cystinuria and will be homozygotes, and 50% will be unaffected carriers. But there is indication that autosomal dominant inheritance is responsible for some of the 7A9 gene mutations, resulting in 50% affected and 50% unaffected children. One of the parents is affected. The main question in cystinuric patients is whether there is a difference between different genotypes and the patient's phenotype. The old classification of cystinuria was the one described by Rosenberg, classifying the disease in type 1 and non-type 1, and the patients in homozygotes, which were symptomatic, and heterozygotes, which were asymptomatic. The new classification, however, recognizes three types, type A, B, and AB, accounting for 45, 53, and 1 to 4% of the cases respectively. The classification is based on the gene responsible for the defect. Stone formation in homozygotes of both genes is 90% to 100%, while only type B carriers form stones in 2 to 18% of the cases. There is no clinical difference in phenotype, meaning the age of present patient, the number of stones, the interventions between the three genotypes, except that patients with AB mutations may show an earlier or later age at presentation. Regarding diagnosis, early and correct diagnosis of cystinuria is essential, as 1/4 to 1/3 of the patients present with a late diagnosis. Important but not obligatory tools to diagnose cystinuria and cystinuric patients are medical history, genetic genotyping, stone analysis, laboratory investigations, and imaging. We should suspect cystinuria in patients younger than 30 years of age with large or bilateral stones, or those with siblings with stone disease. Genotyping is not performed routinely. it is not useful actually for for making the diagnosis, but it is important for genetic counseling within the family. Stone analysis for these patients identifies pure cystine stones in 80% of the cases and mixed with calcium oxalate, calcium phosphate, or magnesium ammonium calcium phosphate stones in the rest of the cases. Microscopic urine analysis reveals the typical hexagonal crystals in only 25% of the cases, while the colorimetric qualitative cyanide nitroprusside test shows low sensitivity and it is not in wide use anymore. The most important tool, especially for guiding therapy and monitoring cystine patients, is the 24-hour urine cystine levels measured by the high-performance liquid chromatography. Normal values are less than 80 milligrams per 24 hours, with homozygotes patients excreting more than 1 gram per 24 hours. And you can also see the levels of the normal values or the relevant values for children in the slide. Two other tools for patient monitoring are the ion activity product of cystine and the litholink assay for measuring cystine capacity, which is actually defined as the amount of cystine that can artificially be added into the urine specimen before precipitation. Their significance is unclear and they are not widely used. In imaging, cystine stones can be seen in KUB in 85% of the cases due to the sulfur band. CT scan shows a Hounsfield unit of less than 550 in 80% of the cases and can differentiate rough stones that break easily with shockwave lithotripsy from smooth stones that are resistant to shockwave lithotripsy. Now, regarding management of cystine stones, you have to remember that when a patient comes with cystine stone, it may pass the stone spontaneously like every other stone patient. Don't forget about that. However, patients may need a lot of procedures in their lifetime and at least one every other year. Treatment algorithm is based mainly on stone volume, stone size, and follows the algorithm of the rest of the stones as defined by the European Association of Urology Urolithiasis guidelines. In past, following treatment, percutaneous or transurethral chemolysis with tromethamine E and acetylcysteine followed. With the advent of new equipment and stone disintegration devices, this method is almost obsolete. Stone prevention follows stone treatment, and actually, prevention measures include adequate fluid intake. One should take more than 4 liters per day in adults and more than 1.5 liters per square meter of body surface in children. Reduce protein intake to 1 gram per kilogram per day. And we should be careful when we reduce protein intake in children. Low salt intake, less than 6 grams per day, that will end and result with low sodium intake, less than 2 grams per day, as well as the avoidance of food rich in cystine and methionine, which is a precursor of cystine, actually, such as eggs, Swiss cheese, tuna, and others that you can see on the slide. Secondly, as cystine is dissolved in alkaline pH, urine alkalinization is used. Most commonly, potassium citrate on 5 to 12 grams per day in adults and 0.1 grams per kilogram per day in children is used. Alternatively, sodium bicarbonate, 4.5 grams per day, can be used. The aim is to raise urinary pH more than 7.5, which is beneficial to cysteinuric patients, for cystine stones to dissolve and not cystine crystals to dissolve and not form again. Careful we should be with high pH because it may calcium phosphate stones may precipitate. And when cystine, actually urine concentration increases more than 3 millimoles per day on the previous treatment really fails, chelating agents are used with the European Association of Urology recommending thiopronin, Thiola as the best agent. The stone depends on the cystine 24-hour urine level starting at 250 milligrams per day to control for allergic reactions and increasing up to 2 grams per day in 3 to 4 doses. The compound of cystine thiopronin is 50 times more soluble to cystine alone. Other drugs include the D-penicillamine, 1 to 2 grams per day divided in 3 to 4 doses, and captopril, 50 milligrams 3 times daily. However, the D-penicillamine is rarely used due to severe side effects, while captopril did not show consistent results and is not used widely. Aggressive medical management can reduce the incidence of stone formation by 78%. The compliance to fluid intake and the compliance in general to this patient is really problematic, but the compliance to fluid intake and diet is moderate, while the long-term compliance to medication is less than 70%. Alpha-methactopropiol glycine, the Thiola, the thiopronin, shows a better profile with discontinuation of only 30% of the patients in the long term. New drugs are tested for clinical trials, but are only in clinical trials for the moment, as alternative ways are of treatment, which are experimental also for the moment, and include crystal growth inhibition of cystinuria, crystal aggregation inhibition, or gene editing interference. Follow-up is very important for cystinuric patients like every other patient, and is significant and should be performed initially every 3 to 6 months, and should be adjusted to the patient's need after that. Future directions look at the entirely different molecules that promote nucleation, and their inhibition could also be important in the future. So as a take-home message, a slide for our junior patients actually, because we treat children with cystinuria. The cystinuria is an inherited defect in amino acid renal reabsorption, responsible for the creation of cystine stones in the urinary system, which are treated similarly to the other urinary stones. The European Association of Urology guidelines strongly recommend prophylaxis with increased fluid intake, appropriate diet, urine alkalinization, and chelation. And thank you for your attention. And let's see if there are any questions. I have one question. Thank you for the nice comment. Do we use crystalluria in the cystinuria follow-up? Yes, we do actually, because there is a prediction. We cannot quantify the result, but this is a qualitative result. If we don't see in the follow-up the crystals, if we see the crystals at the beginning and the crystals disappear after the treatment, then is a good indicator that we treat the patient correctly. There is a general question, not for cystinuria. If a stone chemical analysis predict the need to do a genetic screening for the patient, so we don't perform chemical analysis. It is spectroscopy that we perform. The chemical analysis is not really reliable. And of course, if you do the stone analysis that you should do in every patient, and you see that the stone is a cystine stone, then you have to counsel the patient and probably the family. It's not, as I said, it's not really needed to have the family checked or the patient sent to gene analysis. It's not to make the diagnosis, but for genetic counseling of the whole family, is really important. Is there a role of high pH water in the prevention, since there is a trend of drinking high pH water? That's a very good question. Yes, if I go back to the slide, you will see that it is recommended to have alkalizing foods and alkalizing beverages. So high pH water is recommended on these patients. We should be a little bit careful about high pH for two reasons. First of all, we should aim for pH more than 7.5 and up to 8.5, because at this range, the system is dissolved nicely, but at the same time, calcium phosphate stones may precipitate. So there is another question that I found very difficult to obtain pH more than 7 with potassium citrate and allow compliance with high dose treatment. However, sodium bicarbonate is difficult to manage with hypertension. Any recommendations? That's an extremely good question, but Jose, if I pronounce it well, you are not the only one who has this problem. All the cysteinuric patients and urologists in clinical practice have the same problem with alkalinization of urine. Achieving a pH more than 7.5 has to be, needs a dedicated doctor and a dedicated patient also. And this is always difficult, because potassium citrate and sodium bicarbonate are not devoid of complications also. The alternative, we should go for the treatment for the chelating agents. There is no other alternative, actually, and we should underline that while on chelating agents, we should keep the alkalinization on, so the patients should take potassium citrate. But you're right, it's very difficult. I don't have another clue on that. So the combination therapy, I mean, is very important. Does anybody else want to ask something else? The three of us, it's not only about cysting, stone. I would like to ask my colleagues, there is a question that I see, if there are any, not comorbidity it says, but is there any relation with inflammatory bowel disease with stones and genetic relation? If one would like to reply.
If I can answer, there is certainly an association between inflammatory bowel disease and kidney stones, of course, because there is a condition of malabsorption which can increase the absorption of oxalate in the gut, and then the amount of oxalate in the urine. And this can, in some cases, it might mask a condition of primary hyperoxaluria, but there is not any direct genetic involvement in this.
Thank you, Pietro. I have another question, which is actually related to cystic stones. If there are any new agents for percutaneous dissolution therapy. They have been used a lot actually in the past. There are no new that I know, like ascorbic acid, but as I said, tromethamine E and acetylcysteine was used in the past. But it's a very complicated treatment, I would say. And with the advent of all the mini PERC, the standard PERC evolution, and the flexible ureteroscope, we managed to not to leave fragments behind, so it's not widely used anymore, the percutaneous dissolution. For Dr. Oliveros, a resident, okay. In children with kidney stones, should dietary foods be stopped? Dairy, sorry, foods be stopped? Actually, no, if I can reply, because we know that if we stop the dairy products, then in every patient, especially in children, also in children, as far as I know, then you may increase, and your patient does not take a sufficient amount of calcium, let's say 1 gram per day at least, then he may actually form more stones because you leave oxalic acid free in the gut, and this is reabsorbed.
And there's also a risk of bone disease as well.
And there is also, that is correct. There is a question for uric acid stones, but this is not for the topic today. Sorry, because now the questions are coming, which is very nice. There is another question, which actually, I don't know, I asked Pietro, if you know, regarding the uric acid stones, is not on our topic today, if the SLC38A2 gene was tested, and I think you mentioned something in your presentation. A quick answer, if you like.
So in terms of GWAS studies, there is only one GWAS study that I know of that has been performed on uric acid nephrolithiasis. It was a very small study with less than 100 cases in Sardinia, and it was very small, so very underpowered, but it didn't show any association with that particular
okay.
gene.
I have another from Norminen question. If I could categorize the treatment strategies for cystic stones, and the question actually is quite clear, because he asks us whether patients could rely only on dietary treatment. Unfortunately, the answer is no, because you should combine dietary treatment together with the dietary treatment and increase of fluid intake. Most of the cases actually necessitate to take alkalization of the urine, and if this fails, and that usually, and depending on the urine output of cystine, if it is more than 300 millimole per day, then you should give thiols, and that is the way we treat cysteinuric patients. We have some good comments. Well, we have a general question. If we had an analysis in stone that shows a test of calcium oxalate monohydrate is not relative or dehydrate stone, should we retest the stone in future? The answer is yes. Every time you take every stone from the patient, you should test it, because it can change and can be a mixed stone or entirely different stone type. So I cannot see any other question. I hope that we answered all the questions. I don't know if I missed anything. And as we are 5 minutes ahead from oh, there is something more. We can stay all night. What about the role of inherited gut microbiota, since gut microbiota is linked to stone disease? Honestly, inherited gut microbiota, microbes, I don't really know how to answer this question. Inherited gut microbiota, I don't know. If one of my colleagues have heard anything about that, he could reply.
I think that it's probably more important to look at the changes in gut microbiome, which occur mainly with diet. So rather than, because of course it changes throughout life and it changes throughout age as well. So I think the things that are known are that if there is a, for example, post-antibiotic therapy or something, if there's a substantial change in the gut flora, which is then persistent, then that can potentially mean that there's overgrowth of, of certain bugs that can then cause health problems, not just stones. But from a oxalate point of view, the Oxalobacter species, which is present in the lower gut of every human, is very sensitive to various antibiotics, and it very quickly gets wiped out. So the problem is when it doesn't then repopulate so well, and if that continues over a period of time, that can give rise to enteric hyperoxaluria, or at least a tendency to have higher oxalate levels.
That is well known. Thank you, Moochhala. I think this is well known, but regarding the inheritance, I don't have anything in mind. There is another question. It's a clever question, actually, from Dr. Lukianova. In case of successful treatment, how fast the cystine crystal will disappear from the urine sample? Well, honestly, I haven't thought about that specifically, and I haven't measured that specifically. What we do is we start the treatment, and in 3 months' time, we check upon the patient and the reaction to treatment. And quite often, we don't see the crystals if the patient is taking the medication and follows the orders for diet. So I don't know when exactly. I presume that it goes quite quickly, depending, of course, on the levels of the cystinuria you had from, because homozygotes can actually produce more than 1 gram per 24 hours in the urine, so it will take more time for the crystals to disappear if they are there. There is another good question: if we recommend using a 24-hour urine test or cystine creatinine ratio for the adults. As I said, we use the 24-hour urine test to actually monitor the patient, not to diagnose the patient if you see the cystine crystals, or if the stone analysis shows that it is a cystine stone, then you have your diagnosis. However, you use the 24-hour urine analysis for monitoring the patient and actually guiding the treatment. So on the levels of cystine in the 24-hour urine, you make the decision upon the treatment. Regarding the cystine creatinine ratio, yes, you can use it, and I think most of the urologists and we have the nephrologists with us that they are dealing with kids, they use it. But in adults, we don't. There is another, and I think we should finish with that because there is a very nice 2 questions, and we will finish. First of all, from Dr. Simro, and this question goes to both of you guys. Are there any kit type of test that assessing the set of genetic pools in a specific type of stones? We know that there is something in prostate cancer, let's say, very well expanded. But is there anything for stones?
Not that I'm aware of. In terms of published data, there is the 30 gene panel that I showed you. In terms of your actual clinical practice, you can discuss with your geneticist, and you can either create your own panel, or since the costs tends to become very close, you could even try and perform a whole exome sequencing in some patients.
And I have the last question, which is for me, for cystinuria, whether it is advisable to switch between medical treatments of cystinuria to avoid adverse effects, since they are likely lifelong medications. That is a very nice comment, indeed. Yes, the problem with the medication for cystinuria is the side effects, and patients do not follow the medication for a long time. However, you have to think that the medication with the best profile regarding the side effect is theophylline, the thiola. If these really have a serious side effect and the patient does not continue on medication, then the alternative to penicillamine will not work. That's the feeling. And you should go to other medications like the captopril, which is, as I said, used in the past. It's not recommended in the guidelines, and the main reason is because the results are not sustainable. And I think we should there is, the last question is inevitable. We will end up in tomorrow morning, but this question is quite nice. If we must go in preventing other stone types together with cystic stones, this is a very, very good question. The answer is yes, the patients can have, in 20% of the cases, can have a mixed stone, and the cystinuric patients should go the 24-hour urine metabolic evaluation, as apart from measuring the 24-hour urine excretion, as we do for all high risk stone formers. So I think I should end up the webinar at this point. Thank you all for attending. That was a pleasure for us. I have to thank my colleagues. Very, very important to have nephrologists with us, because it's a collaboration of urologists, nephrologists, and geneticians if needed for congenital stone patients. And of course, we have to thank the European School of Urology, and for giving us the opportunity to present this webinar, and of course the two girls that made it real. Thank you so much.